Good evening to every one of you. It's evening in Europe, but there might be a time of delay for some of you because we have attendees from all over the world. My name is Gerry de Beukelare, and I'm General Secretary of the European Board of Cardiovascular Perfusion. I'm very pleased to announce that we have almost 500 subscribed attendees for this webinar, so I suppose we picked 3 interesting topics for you. Nevertheless, I don't want to spoil the precious time of our speakers and would like to move on and give the word to our chairman, Alexander Wawa. Alexander holds an important position in our society since many years, so enjoy the upcoming hour and the floor is yours, Alexander.
Thank you. Good evening, everybody, and welcome to the first EBCP webinar. The European Board of Cardiovascular Perfusion has a mission to improve perfusion education in Europe, and everywhere else, everybody is welcome to join in. As you probably know, the EBCP organizes a big and successful perfusion conference in conjunction with the EACTS meeting every year. Last year, we had the meeting in Lisbon, and hopefully we'll have a meeting this year in Barcelona. But in addition, we thought that it would be a good idea to try out new flexible forms of education, such as webinars. And during the current pandemic, several organizations have organized webinars and have led the way. The first EBCP webinar will also focus on COVID-19 related issues, which are relevant to perfusionists, but also other topics will be discussed. I would like to thank everyone who has contributed to organizing the webinar and make the webinar happen. Dear participants, I hope you will find this session worthwhile, and please let us know your opinion and suggestions for improvements to make future webinars even better. Now I would like to hand over the word to Carol, who will announce the first speaker.
Thank you, Alexander. Well, our first speaker is going to be Al Stambers from Tennessee. No, right now I'm in Pennsylvania. I've known Al for a long time, and he's actually, his passion is really education and teaching of students, whether they're perfusion or not. He's really spread the word. He's published over 300 papers. He's a past president of AMSECT, also past president of the Journal of Extracorporeal Technology of JECT. He serves in the US on the FDA for cardiopulmonary products. And he works for specialty care, and he directs the quality and research and manages what they call the Scope Perfusion Registry with over 400,000 cardiac procedures. So I would like to welcome Al Stambers as our first speaker with our webinar, and he's going to be talking about putting patients back on cardiopulmonary bypass post-COVID, ready or risk. So Al, I give you the floor.
Carol, thank you very much, and good day, everybody. I want to commend the European Board of Cardiovascular Perfusion on putting these wonderful venues together. Difficult time, and we appreciate all the work that Gertie, Alex, and so many others are doing. I believe, I'm sorry, but I am disabled. Can somebody enable me so that I can show my screen? I'm getting a comment that says host disabled attendee screen sharing. I'm still having an issue getting my slides up. The share screen seems to be disabled on your side.
We're working on it, Al. It will be fixed in a few minutes.
Okay,
Sorry
thank you.
for that.
No worries.
I was talking away, but I was on mute. While we're waiting for your presentation to come up, perhaps then we can just start a little bit talking about the COVID patients. Because specialty care has over 200 hospitals in the US, what is the scope of the number of patients that you see coming in as a total in all those centers?
Yeah, whoops, let me see. Okay, yeah, Carol, that's a great point. And I'll go ahead through a few of my opening slides so we don't have to go back and do that. So thank you, that's a great question. As of the first week in April, we had seen an overall reduction of near 70% of our caseload. We reached the nadir on approximately April 8th in the United States, and that was confirmed with other large data analytics that were done throughout the country. I'm sure it's very similar. The time frame may be different in Europe. And then as of last week, we were back up to within 25% of our 2019 numbers, so that we're seeing an incline, and using that trajectory on our analytics, we anticipate being back to 100% of our 2019 numbers, which are about 45,000 open heart procedures and 65,000 autotransfusion procedures by mid-July, if everything goes as we expect it will. I'm just going to continue on, and I'll keep on testing to see if my screen sharing works, but I'm going to move on so we don't get too far behind. Some of the issues that we're facing today are the variability amongst testing procedures. Right now, the polymerase chain reaction and antibody testing are the two dominant tests that are used throughout the world today to determine COVID susceptibility and COVID exposure. And the problem is they're about a 10% false negative rate with these, even the best procedures, the tests that are out there. And also that if we use symptomology as a means of determining whether or not a patient is potentially COVID positive, we know there's a 5-day delay, and we also have, of course, asymptomatic transmissions that are going on. 2 weeks ago, we began a process of monitoring all of our cardiac procedures for COVID testing. And between May 14th and May 31st, we did just under 1,000 open heart procedures. And what we have found was very interesting. Only 64% of individuals were testing patients prior to coming for cardiac. This was all cardiac surgery, and 35% of individuals either had no test or unknown. And then when we looked at whether or not the procedure was an emergent salvage, urgent, or an elective, there was no difference in that type of testing. So it wasn't just that people were coming urgently for surgery and did not have the ability to get testing. And that's important because
sorry, Al, sorry to interrupt. You can try again. I think it should work.
Ah, wonderful. Thank you so much. Oh, I appreciate it, Luke. Let's see if I can get this up. And okay, Luke, can you see my slide? Or Carol, anybody unmuted? Yes?
Yes, we can see your slides now.
Thank you very much. Sorry, guys. Thank you, Luke. Okay, so this was a study out of Wuhan that occurred, and they looked at a number of patients that had undergone screening for COVID before surgery, and 34 patients were found not to be screened, and that they ended up being COVID positive. And why this is important is the individuals had overall, when they operated on, and this was a broad range of surgeries, over 21% died after the procedure, and 45% were admitted to ICUs that normally wouldn't have been. So you can see the two quotes on the right, and basically if you don't have testing, you almost have to suspect that all of your patients that are coming are COVID positive and prepare accordingly. On the left-hand side, these are the recommendations, and there are multiple recommendations that are out there from professional societies. We're very pleased the European Board of Cardiovascular Perfusion is part of this international task force of multiple organizations, and have been conducting some webinars as well. And just to look at a couple of societies, the Europeans and the Americans and others have put together these position papers, and really what they're focusing on is triaging patients in regards to coming for surgery, dealing with safety, both patient-related and clinician-related, and talking about alternative blood management alternative management techniques for these patients. Anesthesia guidelines are also out there, mainly out of China. So I'm just going to conclude over the next several minutes with some of the considerations to take into account when you're performing cardiopulmonary bypass. It's important that no guidelines that exist, and I am not presenting guidelines here. This is just a guidance of what we feel with our experience, mainly in ECMO. We've done just under 100 ECMO procedures to date that are COVID-19, and we've learned quite a bit on that. And this is extracted from a paper that was submitted. It's in its second revision to Perfusion that Professor Guanaiden and I had written. So there's 4 areas that we're just going to conclude with: coagulation, inflammation, pathogenesis, and then the conduct of bypass. We're not going to spend much time going over the pathogenesis, which has been explained in multiple publications. But these are the conditions that we're all presented with: severe hypercoagulability, both on the venous and arterial side. Most of the patients are on some sort of thromboprophylaxis, low molecular weight heparin. We've got a situation here with DIC, acute phase reactants with hyperfibrinogenemia, low AT activity, and then reduced fibrinolysis, which also enhances thrombophilia. On the inflammation side, we know, or everybody on this particular call has heard of the cytokine storm, hypercytokinemia, and this results in an increased vascular hyperpermeability and an endothelitis. So this is something that we as perfusionists and those in cardiac surgery need to be aware of. The abnormal tests we know that are occurring, these are reported in almost all papers associated with COVID. And then recently there's been this report of the severe endothelial distress syndrome, SEERS, which is occurring, which has been described in other areas of critical care, but has been applied to COVID. And then we know that it's attacking multiple organ systems. So I'm going to conclude over the next 4 or 5 slides with what we're able to discern from the literature. And unfortunately, most of what we learn is from case reports. There have been 5 case reports published to date as of yesterday that have dealt with COVID patients. 3 out of the 4, actually 3 out of the 5, have resulted in death. These were non-diagnosed individuals who went on for surgery, had an uncomplicated surgery. 1 was in Italy, 2 in America, and then they died within the 11 operative days thereafter, post-operative days. This 1 paper out of China on 4 aortic dissection patients, all of those survived. So what should we consider? These are considerations, and as I mentioned, they're not recommendations so much because we're using inferential evidence to determine what we should be aware of and what we should consider in the realm of cardiovascular perfusion. None of these recommendations, by the way, are outside of the instructions for use of the operating parameters of the devices that we all utilize, but they are on the upper side, the most of them. So gas exchange, we understand that compromisation may occur. There's a lot of controversy right now why hemoglobin may be affected, the periphery of it, but we're recommending that larger capacity oxygenators be used. Using aggressive sweep rates in FiO2 management. What we've learned from ECMO, these patients are very volatile and have varying responses to gas exchange. Optimizing hemoglobin and transfusion is a whole nother talk, but we're not going to go over it today. There's a slight chance that the virus is transmitted through blood. So with that, it's probably a good idea to use exhaust port gas scavenging, such as a Bain system. These patients develop myocarditis, and they have, and of course, our heart patients outside of the congenital realm tend to come with us already and compromised with multifactorial issues and confounding issues associated with comorbidities. So optimizing oxygen carrying capacity through the use of sanguineous solution, higher dosing to reduce any microvascular or macrovascular thrombi and minimize ischemic time. And as far as Del Nido and HTK, it's unknown whether or not we should be recommending that. Coagulation, probably not a surprise to anybody on this call. Higher doses, we normally shoot for 3 to 5 units of circulating heparin per cc of plasma volume. Most people are recommending 6 to 10, which are met by these two first bullets. Frequent ACT monitoring, bivalirudin, 20% of our patients have switched to the DTIs on ECMO. Stay away from antifibrinolytics. It's the only thing that may be keeping the blood liquid. If we knock out all fibrinolysis, then blood will, of course, become very thrombogenic. AT maintenance, and of course, consider TEGs. These have been wonderful, and several reports recently have shown that they identify hypercoagulability. Ultrafiltration, both cuff and Z-buff, perhaps even the utilization of a cytosol filter. It's used primarily in Europe, and we're starting to see reports of it here in America. Intraoperative cell salvage to optimize carrying capacity. It also lowers the fibrinogen concentration by a quasi-plasmapheresis technique. Keep in mind, though, that it is an aerosolization hotspot. So that's something that we have to be aware of, and that's shown in safety. Safety, this traditional PPE for COVID patients. Do not use any reusable drug trays, which are the standard in America. Limit equipment, so use only certain equipment for COVID positive or COVID suspected patients. And then, of course, disinfect the room. The aerosolization hotspots that are occurring, we know that we stay away from patients during intubation for up to 30 minutes. Venous reservoir cell salvage, VAVD is probably, should be seriously considered because it does cause a disruption in blood-gas interactions and to scavenge. My second to last slide here just shows the recommendations in a summary format that we're putting forth. And also simulation. I think it's a good opportunity for us to practice simulation, especially when it comes to oxygenator changeouts, which most of us see only one time in our careers. So there are no guidelines presently for bypass in COVID patients. Where to focus are coagulation, gas exchange, inflammation, hemoconcentration, and myocardial protection. And then safety with enhanced droplet precaution should be the mandatory foundation by which we keep not only our patients safe, but also ourselves. So with that, I thank you, and I apologize for the initial problem with getting the slides up, but appreciate everybody's attention, and I thank the European Board for allowing us to present this.
Thank you, Al. That was really a very good, concise. As I say, you focus on effectivity and on safety for the patient, and just sharing your experience of everything from specialty care. We really appreciate it. So we can bring it back to our practice. We have two questions that came up. One is from Ian Shearer. Hello, Ian. He's watching webinars instead of sailing. I normally see him sailing. He says, Al, would you comment on the merits and lack thereof of cytokine filters in the OR or ICU setting?
Yeah, there's really, thank you, Ian, for the question, and thank you, Carol, for passing that on. Yeah, there's really not a lot of work. Most of the work has occurred in Europe, and we only have one patient to date that's had this filter placed, and it was actually during ECMO, and we actually tried it before ECMO, and the patient ended up going on ECMO. From a conceptual aspect, clearly reducing the cytopenia that is occurring should be beneficial. Nobody on this call is not concerned with hyperinflammation, and we as perfusionists deal with non-endothelialized surfaces throughout our practice, so we're aware of this. Unfortunately, the data has not caught up to supporting it yet, at least with COVID patients. And I think that's a common theme we'll hear from the other presenters too. We're just dealing with inferential and our gut reactions so far, which we know are not the best when it comes to science. So just not a lot of work on it yet, Ian, but we're hoping, and I know you at Duke, I believe, have used these filters, so do appreciate your experience.
Mm-hmm. I think, Garrity, did you want to answer that live, did you say? Or maybe not. Okay, there was another question also too from Harvey Ellis, and he asks you, what PaO2 do you suggest, high or low?
Yeah. Thanks, Harvey. I do appreciate the question, and thank you, Carol. We're staying in the high range. Normally, the conduct, at least in the American realm, is between 150 and 300. So we're not recommending hyperoxia, which obviously has some profound pathophysiologic consequences as well, but we're recommending that individuals stay on the 300 range, which is on our high acceptable tolerance. And that just, what I'm stating is that we're staying within our relatively range of operative parameters by staying on the high side until we start collecting more information on these patients. We've only had one positive COVID that we've put on bypass so far that we know of in the last 2 weeks. And there weren't any sequelae that were associated with it. So as we're tracking this and we find more information, we'll be able to update our recommendations.
Okay, very good. So with that, I think now we reached the time. Thank you very much, Al. And also now I would like to introduce to you the next moderator. And that's going to be Adrian Bauer. And Adrian is a very good colleague of mine. I've known him since he's been in the beginning of Perfusion. He's also gone through a lot of educational years and reached his master's and PhD. So he's Dr. Adrian Bauer. His great focus is minimal invasive circuits, and also a big passion for recognizing perfusion as a profession, and to get that officially stated in Germany. So he's putting a lot of work in that. He's a chief perfusionist at the Cardiac Center Coswig, Germany, the president of German Perfusion Society. He's also part of the EBCP accreditation subcommittee. And with that, he's a really busy guy and he's a really nice guy. So I'd like Adrian now to take the podium. Cheers, everybody. I'll stay here, I'll listen.
Carol, thank you very much. I think for all that, what you say about me, a long talk, but I think the next moderator is Luke, and Luke is prepared for the next presentation.
Oh, sorry about that.
No problem.
Okay, I thought it was going to be on.
Okay, thank you all. We'll continue with our next speaker. My name is Luc Buys, by the way. We'll continue with our next speaker, which is Professor Dr. Tom Verbeelen. He's part of the cardiac surgery team at the University Hospital in Leuven, Belgium. And he has a special interest in the right heart, the physiology and pathophysiology of pulmonary hypertension, and also special interest in pulmonary thromboendarterectomy. And he will give us a talk about a new kind of oxygenator that he's doing research on. Dr. Verbeelen, the podium is yours.
So thank you, Luc, for this kind introduction. Dear colleagues, in our journey towards the development of an implantable artificial lung, I would like to discuss the integration of compliance in the design of an oxygenator. As you all know, mechanical ventilation is associated with oxygen toxicity and barotrauma. Patients are often sedated and bedridden, so resulting in a decreased quality of life and deconditioning. Ventilation-associated pneumonia is one of the most significant complications of mechanical ventilation, and patients with advanced lung failure refractory to this mechanical ventilation will require ECMO. And if these patients have become too deconditioned and sick to expect recovery, they need to undergo a lung transplantation within a few weeks. And this was the conventional strategy, but a new and evolving strategy is based on the concept of allowing injured lungs to rest and recover by reducing airway pressures and tidal volume. So using artificial lungs instead of mechanical ventilation at an early stage in the disease progression may prevent patients from being sedated and could allow them to eat, drink, and mobilize. And this in turn then will improve their physical status and organ function, resulting in a better quality of life and survival. Ventricular assist devices, or VATs, are now used as bridge to recovery, bridge to transplant, and destination therapy. And although it's not a perfect solution, at least it allows patients to live on chronic support at home for several years. So compared to VETs for heart failure, lung replacement technology is lagging behind, not allowing discharge on device. Artificial lungs can be divided into 3 types: extracorporeal devices like ECMO, paracorporeal devices, and fully implantable devices that are still under development. Now, as bridge to transplant, we currently use ECMO, which has several advantages, however also several limitations, but I will not discuss them for the sake of time. A paracorporeal device, however, is located outside the body, but its connections are on the central large blood vessels and generally do not require a blood pump. So this configuration was initially driven by the unique pathophysiology of pulmonary hypertension, but this requires then, of course, an oxygenator with a low resistance. The commercially available artificial lung with the lowest resistance is the Nova lung. The resistance is about 5 millimeters of mercury per liter per minute, or 5 Wood units. In comparison, the resistance of a native healthy lung is around 1 Wood unit. Camboni and his colleagues, they reported 62 days of Nova lung support in a pumpless pulmonary artery to left atrial configuration, but with a need of 4 oxygenator exchanges in that time period. However, due to the relatively low oxygenation capacities, mechanical ventilation was still required. Another promising device is the MC3 BioLung. It has a low resistance of only 1.8 Wood units, and Sato and his colleagues, they conducted a 30-day study in sheep, also in the PALA configuration, and they observed stable hemodynamics, blood gases, and organ functions. However, the device needed to be exchanged every 9.5 days because of blood formation. So on our way towards a completely implantable lung, in my opinion, we should address 4 major design issues. First, gas exchange, also hemocompatibility, hemodynamic compatibility, and then the size and the shape of the design. So in my talk of today, I will focus on hemodynamic compatibility. And 2 key components, in my opinion, are the mode of attachment and the impedance of the device. So in-series implantation uses the proximal pulmonary artery as inlet and the distal pulmonary artery as outlet of an artificial lung. In parallel attachment shunts blood from the pulmonary artery through the artificial lung to the left atrium, and this offers then a low resistance alternative for blood flow, and it lowers the stress on the right ventricle. So it may be best suited for patients who are suffering from pulmonary hypertension, despite several disadvantages. But the focus of my talk today is right ventricular afterload. This is determined by a concept we call impedance. So the impedance of the lung consists of the pulmonary vascular resistance, the compliance or the extensibility of the pulmonary vasculature, arterial wave reflections, and the inertance of blood. In the healthy pulmonary circulation, this large compliance causes the arterial wave reflections to decrease in amplitude and speed, so they arrive back to the heart during the diastolic phase. And with a stiff arterial system, like in pulmonary hypertension, but also when we use stiff fiber bundles in an oxygenator, these wave reflections remain large and they return during the systolic phase, directly opposing the forward power of the right ventricle. Adding compliance or a compliance chamber to the design of an oxygenator was first described by Lick and his colleagues, and they implanted such a design between the pulmonary artery and the left atrium and fully snared then the pulmonary artery. So the whole cardiac output went through the device. And with a compliance chamber, they measured a significant lower resistance and a higher cardiac output than without compliance chamber. Skook and his colleagues, they recently described their compliance total artificial lung, which uses a compliance biospan polyurethane housing. It has a resistance of only 0.5 Wood units in vitro, and chronic testing for 14 days without anticoagulant coatings showed a resistance of 1.04 Wood units, while organ function remained normal. There was only minimal clot formation and no blood damage and no need for blood transfusion. So now it's my privilege to present to you a new design named RESQ. And this design includes actually the classic use PMP, polymethylpentene fiber bundles, but with compliance elements in defined positions inside these fiber bundles. These are silicone tubes. And previously conducted in vitro studies showed that it had a minimal pressure loss of less than 5 millimeters of mercury and good oxygenation and decarboxylation capacities. So about 2 years ago, when we started this project, we performed 6 acute trials with the first prototype in the PALA configuration. And to mimic pulmonary hypertension, we bended the pulmonary artery. And we did our measurements at baseline condition, at moderate and at severe pulmonary hypertension. So in one experiment, we also benchmarked this device with the Quadrox-E because this device has similar dimensions and we used 2 separate parallel circuits. Now, at moderate pulmonary hypertension, the device significantly lowered the pulmonary pressures. It provided about 31% of the total cardiac output towards the left atrium and significantly decreased the ratio of pulmonary on arterial blood pressure, indicating a good unloading of the right ventricle. At severe pulmonary hypertension, the device led to a significant increase in arterial blood pressure and cardiac output, with a slight increase in pulmonary pressures, but all of these 3 indicating recovery from acute right heart failure. 39% of the total cardiac output went through the device, and also here the ratio of pulmonary pressure on arterial blood pressure significantly decreased, again indicating a successful unloading of the right ventricle. Our benchmark with the Quadrox device showed that in each condition, rescue provided an obviously higher percentage of the total cardiac output towards the left atrium. And also the ratios of pulmonary on arterial blood pressure were obviously rescue, so indicating a better unloading of the right ventricle. Now, when we opened both parallel circuits at the same time, we saw in each condition a 3 times higher flow through the rescue device. But this first prototype, however, was designed for an oxygenator flow of about 1 liter per minute, and a second prototype was designed to aim for a more realistic flow rate of 2 liters per minute. And meanwhile, I have to credit Librida Frisiello, who joined our department, and she shipped over her hybrid cardiovascular simulator, which is a combination of a computational and a hydraulic simulator. And so about 2 months ago, we were able to use this simulator for our new second prototype. So 2 chambers were used, one mimicking the pulmonary artery and the other one mimicking the left atrium, and the oxygenator was then obviously connected accordingly. Here you can see the pressure volume loop of a healthy right ventricle. Now, when we simulate moderate pulmonary hypertension, the ventricle starts to work with higher volumes, higher pressures, and lower stroke volumes. And this effect increases when we model severe pulmonary hypertension. And a last situation we mimicked was cardiogenic shock due to RV pressure overload, which you can see here as the green loop. If we start with moderate pulmonary hypertension, and if we connect the rescue device with these silicone tubes inflated to 100 millimeters of mercury, then we mimic the absence of compliance. Then we see this loop. So with a flow of 1.36 liters per minute through the device, the pulmonary pressures decrease, arterial blood pressure and cardiac output increase, and there is also a clear unloading of the right ventricle because our end diastolic volume, as you can see here, and central venous pressure, but also our peak pressures clearly decrease, and our pressure volume area as a parameter of the ventricular oxygen consumption all decrease. Now, when we leave the lumen of the silicone tubes open to the air, we see the effect of integrated compliance. And that is seen here. So the flow through the oxygenator increases towards 2.93 liters per minute, and organ perfusion increases, and right ventricular unloading improves further. And the same effects were seen in the severe pulmonary hypertension condition and also in the cardiogenic shock condition. So from these experiments, we concluded that an artificial lung in the pulmonary artery to left atrium configuration improves cardiac outputs, provides right ventricular unloading, and that these improvements are amplified by incorporating compliance in the artificial lung design. And although cardiac output increases the most in the cardiogenic shock condition, RV unloading was more pronounced in the severe pulmonary hypertension condition, so illustrating probably the benefits of implanting an artificial lung earlier in the course of a disease. Now, final words on durability and portability. So for portability, implantable artificial lungs will definitely improve the quality of life. However, a paracorporeal placement allows for easier detection of clots, easier device repair, device exchange, and there's also fewer restrictions on size and design. So in conclusion, implantable artificial lungs do not yet exist, and paracorporeal devices should become commercially available sooner. And I think these three previously discussed devices are, in my opinion, designs to keep an eye on. And although not discussed in this presentation, please also keep an eye on the field of microfluidics, because this might lead to the development of a completely new design of gas exchangers with even the promise to use ambient air as sweep gas. So, but I think our primary goal for next decade is to establish an implantable artificial lung with low impedance. So this means low resistance and high compliance with a high durability and good biocompatibility, because only by addressing these requirements, survival and the quality of life of end-stage lung failure patients might improve. And as such, technology might eventually even replace the need for lung transplantation. Thank you for your attention.
Thank you very much, Dr. Belen. It was an excellent presentation. This looks really promising. When you say that there's no open questions from the audience, but I have a few questions. So you say that the next decade will be, you had a lot of work to do. When do you think these devices will be actually commercially available for patients?
Well, I think that's a hard question. It will all depend on industry and how much money and time they would like to invest in this. Realistically speaking, we now are in the phase of animal trials. So I think that at least it will take another 5 years before, before the first in men can be tried, and we have several ideas for the first in men, because of course one of the major issues will not be the hemodynamic compatibility, but rather the hemocompatibility. So first in men trials should be, well, let's say as short as possible. And so you will not try this in a long run ECMO situation, but rather, for example, during a lung transplantation, just to bridge the transplant period.
Yeah. And then one more short question. We have 2 minutes left. Which kind of anticoagulation do you think you would need, or would you need any anticoagulation for the rescue device that you promote?
So I think that's a very good question. We're not yet in that stage to test this. Probably yes, you will need heparin, but it's a question I cannot answer at this moment. Although what seems promising is that all the other compliant devices seem to work well in animal trials, even without any anticoagulation. And the specific or exciting thing about this design is that we think that by placing these silicone tubes, these compliant elements, in specific zones within the design of the oxygenator, so in the spots where we expect to have clot formation, that when we place the silicone tubes over there, that we get a better washout of the oxygenator, and so we can prevent clot formation. And then when we're thinking further, we have even, because what I discussed now was actually a passive compliance, but you could also like actively inflate and deflate these silicone tubes, for example, based on the ECG signal. And then of course you will improve your washout even more. So, and based on what the effect is of this technology, we will have to determine our anticoagulation strategy.
Okay, thank you very much, Dr. Verbelen. So we can now move on to Adrian, who was nicely introduced by Carol earlier, and he will introduce our next speaker.
Yes, thank you, Luke. And once again, I will also introduce you. Now we make it from the other side.
No need to.
Luke is working for the Option and Outcome Committee in the European Board for long years, and he was also the chairman of a very important paper, one of the important papers for us in Europe, I guess, the guidelines on cardiopulmonary bypass in adult cardiac surgery, published last year. And I can tell you, I often use that paper for RQ, for my administration, for my daily work. I look in it and I send it out a lot of times. So a very good work.
Thank you.
Luke is now in America, in US, and hopefully, probably he come back to Europe sometimes. You are always welcome. You know that.
Thank you. I am now. So.
Okay. Thank you all, also to the first speakers, very interesting talks and presentations. And I want to introduce now the last speaker for tonight. And this is Dottore Enrico Baldi from Italy. And most of you know that Italy have a heavy outbreak, and the first heavy outbreak in Europe. And Dottore Baldi is involved in a program investigating cardiac arrest. He is a cardiologist, and he published a very good paper in the end of April in the New England Journal of Medicine. And it's regarding the association between COVID-19 and cardiac, out-of-hospital cardiac arrest. And I'm really looking forward for that presentation, and I will give you the word. Dr. Baldi, it's your talk.
Thank you very much, Adrian, for your kind introduction, and thank you for the invitation. And now I try to share the slides. Okay, you can see it.
Yes.
Carol?
Yeah.
Okay. Good evening. I'm Enrico Baldi, as introduced by Adrian. I'm a cardiologist at the Policlinico San Matteo Foundation Hospital in Pavia, and I'm a PhD student at the University of Pavia. And it is a great pleasure to share with you the results of our paper regarding the out-of-hospital cardiac arrest during the COVID-19 outbreak in Italy, which was recently published on the New England Journal of Medicine. As you know, Lombardy region was one of the first areas outside of China affected by COVID-19, with the first case diagnosis in Codogno in the province of Lodi on 20th of February 2020, obviously. And Italy is one of the countries most burdened by COVID-19, both in terms of total cases, as you can see in the right chart, and in terms of total deaths. And it's as of the 30th of May in the 6th position of this not so good classification. And we perform an analysis of the Lombardia Cardiac Arrest Registry called the Lombardia Care, which is a new stem-based, multicentric, prospective, longitudinal cardiac arrest registry, which enroll all the out-of-hospital cardiac arrests which occur in the provinces of Pavia, Lodi, Cremona, and Mantua in Lombardia region in northern Italy, for a total population of 1,500,000 inhabitants. We compared the out-of-hospital cardiac arrest occurred in the first 40 days of the outbreak with those occurred in the same period in 2019. We also perform a reanalysis of all DMS electronic data, looking for suspected symptoms as fever for at least 3 days associated to cohort dyspnea, or diagnosis of COVID-19 before the out-of-hospital cardiac arrest. In this chart, you can see as the blue columns, the out-of-hospital cardiac arrest occurred in 2020. The orange columns are the out-of-hospital cardiac arrest occurred in the same period in 2019. And the red line is the COVID-19 cases represented as cases per 100,000 inhabitants. And you can see that there is an impressive increase in out-of-hospital cardiac arrest occurrence, accounting for 58% more than the previous year. And we also performed an analysis to verify the association between the cumulative incidence of out-of-hospital cardiac arrest and the one of COVID-19. And the association is very strong with a Spearman rank correlation of 0.87. The results are even more impressive if we look for each province separately. In fact, in the province of Lodi, the increase respect to the 2019 was about 187%. In the province of Cremona, 143%. And the province of Lodi and Cremona was the first provinces affected by COVID-19. And as of the end of April, they have the highest number of cases of COVID-19 per 100,000 inhabitants. If we look for patients with COVID-19 symptoms or diagnosis of COVID-19 before out-of-hospital cardiac arrest, we can see that they are 103 in 2020, and they represent the 28% of all the patients, or the out-of-hospital cardiac arrest patients in the present year. And if we analyze the excess of out-of-hospital cardiac arrest in 2020 compared to 2019, we can see that the patient with the symptoms or diagnosis of COVID-19 are the 77.4%, represent the 77.4% of this difference. So the link with COVID is very suspected. Moving to out-of-hospital cardiac arrest patient characteristic, we can see that in 2020 we have more out-of-hospital cardiac arrest with medical etiology and with home health location, and this is consistent with the quarantine, with the lockdown and social distancing. Moreover, in 2020 there were more unwitnessed out-of-hospital cardiac arrest and less bystander CPR. And this is consistent with the fact that there is a lower percentage of out-of-hospital cardiac arrest occurred in public places, with social distancing, with the conduction of quarantine in different room or house respect to the other member of the family, and regarding the bystander CPR of the fear of infection. Moreover, the cardiac arrest in 2020 were more frequent, not shockable. And this is consistent with the fact that hypoxia probably is the driven of the cardiac arrest. And the fact, as you can see also in this chart, that the EMS arrival time was 3 minutes longer in 2020, probably because of the time needed to wear PPI equipment. And so all these issues led to an increase in patients dead on the field, so a decrease in survival. And in a recent paper accepted yesterday in the European Heart Journal on the same issues from our group, we analyzed also the correlation. And so it's a pleasure to share with you some insights about this paper accepted yesterday, which is in press. And here we focus about the correlation with the excess of out-of-hospital cardiac arrest in 2020 compared to 2019 and the cumulative incidence of COVID-19 in the first 60 days of the outbreak. In this chart, you can see in the lower part the difference in cumulative incidence of out-of-hospital cardiac arrest per 100,000 inhabitants. And you can see that the province with the more excess are Lodi and Cremona. And the Lodi and Cremona province are those with the highest number of cumulative incidence of COVID-19. And we perform a statistical model to verify the association between the excess in 2020 about out-of-hospital cardiac arrest and the COVID-19 cumulative incidence. And we can see that there is a strong association both in all the provinces with a Spearman rho of 0.87 and in each province separately. And in all the provinces, the Spearman rho is higher than 0.80 and reached 0.98 in the provinces of Lodi and Cremona. So the link with COVID-19 is very, very present regarding the excess of out-of-hospital cardiac arrest in 2020. But which are the possible causes that lead COVID-19 to cause the out-of-hospital cardiac arrest? In the last paper we published, it was accepted yesterday, we discussed this issue, and we believe that there are two main branches. The first one are the infection-related possible causes, the rapid progression of respiratory failure at home, the pulmonary embolism, which was demonstrated to be associated with COVID-19, the myocarditis, the myocardial infarction due to the prothrombotic state typical for COVID-19, the heart failure decompensation in chronic heart failure patients due to infection, the arrhythmias due both to drug effects but also to the infection itself. But there is another branch. The other branch is the pandemic-related possible causes. In fact, also in our region, as in other countries all around the world, we notice a decrease of hospitalization for other diseases than COVID-19, especially for STEMI. Probably because patients are afraid to come in hospital due to the fear of contagion, or to the willingness not to further burden on the EMS system. And these have led to the deterioration at home of time-dependent diseases, such as STEMI, up to the occurrence of out-of-hospital cardiac arrest. So in conclusion, we demonstrated that there was an impressive increase of out-of-hospital cardiac arrest in the first 30 days and also in the first 60 days of the epidemic in the most affected provinces in the Lombardia region, and that the cumulative incidence of out-of-hospital cardiac arrest followed closely the epidemic trend in each province. And moreover, we noticed an increase in both medical causes and in non-shockable rhythms, suggesting a link with COVID-19 infection. In fact, the COVID symptoms or diagnosis of COVID were present in a not negligible percentage of patients in the days before out-of-hospital cardiac arrest. And we believe, as a perspective, that the government should consider this pre-hospital challenge when planning healthcare strategies to face the epidemic, especially consider the expected recurrent outbreaks. We believe that there are different strategies to reduce the risk of out-of-hospital cardiac arrest during the COVID-19 pandemic. We have to inform patients to early recognize symptoms of the deterioration of respiratory failure, to exhort patients not only to respect the quarantine, but also not to be afraid to be taken to the hospital in case of need, and even more important, to carefully monitor patients treated at home to prevent COVID-19 from being a disease that kills at home. Thank you for your attention.
Okay, thank you. We still have the presentation open. That's okay. You can see me, right? Okay. Okay, now. Yeah, thank you very much. Very interesting talk and investigation, and you answered almost all my questions. I write down a lot of questions and you answer it during your presentation. It's unfortunately for me a little bit difficult to ask something. There are also no questions from the audience outside this room here. But when I understand it right, we just in the beginning of understanding what's happened with that patients or what's different from a normal patient or normal regular cardiac arrest, if you want to call it in that way, to a COVID patient. Is that right? Do we know everything about it? No.
Yes, we are in front of a pandemic, and so the patient affected are very different from the normal patient we are treating before COVID pandemic. We are working on another paper focusing on the treatment of this patient. We believe that the presence of COVID symptoms or diagnosis prevent the initiation or the duration of resuscitation attempt by EMS. But we found that it was not true. In fact, the patients are more with non-shockable rhythm, more unwitness, less bystander CPR, and this led to a reduction in survival. But the problem is that the COVID-19 led to these characteristics. And so the patient didn't die because they are not treated, but because the COVID-19 infection led to have a characteristic of the cardiac arrest less probably related to a survival. And so, as you correctly stated, the COVID-19 led to have a different patient with less survival chances. And so we have to learn from what we have observed in the last 3 months to be prepared for. We hope that will not a problem, but for expected recurrent outbreaks. So in the next future, we can be more prepared to this pandemic or another pandemic.
I have a question, maybe Adrian, if you allow.
Yeah. Yes, of course.
So the patients that did have an out-of-hospital cardiac arrest, did these patients have a profile of known heart disease, or were these actually cardiac patients, or were they more healthy patients? Do you have a view on that?
So it's a very good point. As all the out-of-hospital cardiac arrest registry, we don't have information of all our patients because they are EMS, they come from the EMS electronic data. But we analyzed as a cardiologist the QT value of the ROSC patients, and we observed that the QTc value of the patients is increased. And so we can assume that many patients can have other cardiac problems. In fact, infarction can prolong QT interval, other pathologies can prolong QT interval. And so we think it is a mix of normal patient, healthy patient, and a mix of cardiac patient. But what we observe analyzing the EMS electronic data is that the majority of the 103 patients with COVID symptoms or suspected for COVID diagnosis are healthy patients. And many of them are conducting their quarantines in another house respect to the other member of the family, and they were found dead the morning after, probably because a rapid worsening of symptoms. And so we believe that a percentage, but a small percentage of patients are already cardiologic patients. But the majority are healthy patients.
Okay. Thank you.
Okay. Now we have a couple of questions from the audience. We know that patients are in and we hear it also in the first talk, in a special coagulation situation. And Dhruva Sharma is asking, what is the protocol being followed for monitoring coagulation profile in COVID-19 patients? Do you have a special protocol for that, or patients? Coagulation?
I'm sorry, go ahead. Most individuals are watching them for DIC and for the acute phase reactants that we know occur, hyperproteinemia, and the elevation in fibrinogen levels and D-dimers. Fibrinolytic potential is real and is actually muted in some patients, and with this this restriction in fibrinolysis, patients' clots form and then don't break down, which cause both macro and microvascular issues and thrombi. So right now, D-dimers are the primary ways. Antithrombin 3 is being monitored quite frequently, especially in the ICU for individuals perhaps not associated with cardiac surgery, but are undergoing ECMO and other invasive support procedures. There's some reports that say there's elevations in PT and APTTs, but most people are using these other mechanisms. Platelet count doesn't seem to be affected. Consumptive coagulopathies are not being reported frequently in these individuals. So DIC is probably the big one, and with that, antithrombin is a good indicator that you're going down that pathway.
Yeah. Okay, so also to make a thromboelastic test could be an option to monitor.
Yeah, I apologize. The TEG and ROTEM are definitely great monitors, mainly because of their ability to show hypercoagulability and lytic function. And a lot of these patients, normally you have a tailing off of a lysis that is occurring. We always refer to it as hyperfibrinolysis in the cardiac realm, but this is the opposite. This is not, clot that's degrading quickly, leading towards bleeding diathesis. These are the opposite. These are individuals who are showing hypercoagulable profiles, very, very thick. If you're using a TEG, it'd be maximum amplitude with low lysis 30, which is normally, I believe, less than 10%. I'm sorry, I don't know the exact number, but these are actually sustained, non-degrading fibrin clots that are present, and that of course just builds upon itself and creates more thrombophilic conditions. Okay,
thank you. Thank you all. I think we are at the end of this 1 hour. There are a couple of questions left in the questions and answer section. And if I'm right, Gerdy, we let that answer and question section open for the colleagues to ask and to discuss there.
Yes, the questions will be answered.
Okay. So then it's it's on me to close the session, right?
Yes.
Yes, okay. Thank you all for coming, for your time to the first webinar from the European Board. It's the first time that we're doing it, and we learn to do it. And thank you very much to the speakers. It was very interesting, and we learned a lot of new things this night or this evening. And thank you all for coming, for listening us. And I say a good day, a good night, a good morning, whatever, where you are. Thank you for being here.
I would just like to add, Adrian, yes, that the certificates will be distributed by mail end of June, and that the link to the webinar will stay open to watch it again. Thank you.
Yeah.
Bye.
Thank you. Bye.